First of all, I would like to thank the organizer for a kind invitation. We move to another theme. Topics is we talk about TAVI. In TAVI, we have a few challenges in the treatment. One of them is vascular access, another is coronary access after TAVI, valve-in-valve, and TAVI in bicuspid aortic valve stenosis, what we talk in this afternoon. As we know, the bicuspid aortic valve is the most common so-called congenital heart disease. It's almost 50% younger patient who undergoing surgical aortic valve replacement has bicuspid aortic valve. Also, older patients, about 8 years and more, also in 25% has a bicuspid aortic valve stenosis. The younger patient with bicuspid aortic valve stenosis has less comorbidity, but has challenges morphology and anatomy with more calcification and leaflets and raphe. Also has concomitant dilated ascending aorta, aortopathy, and concomitant aortic regurgitation. According to the latest guidelines, bicuspid aortic valves suggest to undergo surgical aortic valve replacement as the first choice of therapy. But if we have patient with more comorbidities with high surgical risk, in that patient, we perform TAVI, and it is a class 2B according to latest guidelines. CT, as you know, is mandatory for the diagnostic tool. According to them, we plan our interventions. And what we know to date about TAVI in the bicuspid aortic valve. 1 year's outcome is similar in surgical aortic valve replacement and TAVI in bicuspid aortic valve. As I said, in bicuspid aortic valve we have more calcification. CT also is mandatory to plan treatment. What is the warning? Warning is that we have a high degree of stroke during TAVI in bicuspid aortic valve. Permanent pacemaker requirements also is higher in bicuspid patients. Also, annulus ruptures is a little bit higher percent than in TAVI than in the tricuspid aortic valve patient. The main question is what is the optimal sizing of valve, of which valve is the best options, durability of valve, and what is the evolution of aortopathy in bicuspid aortic valve patient. In the dimension of aortic valve complex in bicuspid aortic valve is larger than in the classical tricuspid aortic valve. In supraannular dimension of sinus valsalva geometry is more elliptical than in tricuspid aortic valve. In 2/3 of patient is a non-tubular shape of aortic valve complex, have more calcification, more horizontal orientation of aorta, and aortopathy is concomitant disease in that patient. The most important classification is Sievert's classification, but for prognostic of the treatment, patient is the more useful classification is according to presence of raphe and the degree of calcification. And the patient with huge calcification on the leaflets and raphe has a worse outcome than patient with lower degree of calcification. When we compare transcatheter treatment of tricuspid and bicuspid aortic valve, that results in treatment is similar according to the stroke and overall mortality and the hospitalization. According to the Notion 2 study from the 10 years of follow-up, that study showed no benefit TAVI in that compared to surgical treatment in younger patient, because in TAVI patient with bicuspid aortic valve has high rates of non-disabling stroke and paravalvular leak. Because of that, we with more randomized, larger control trial to show us is TAVI better than surgery in bicuspid aortic valve. Because of that, it's a bit now, according to the latest guideline, bicuspid aortic valve refers to surgical aortic valve replacement primary. What is the additional challenges? It's the degree of calcification, location and length of the raphe, and SOB width and height dimension. The sizing is another challenges in the bicuspid aortic valve. It's the best option to perform multi-level and multi-perimeter sizing in that patient. According to the Vojvodina registry, patient with multi-level sizing has better outcome than patient with sizing based according to only annular dimension. Technical challenges, first the guide wire crossing difficulties. Pre-dilatation is recommended in bicuspid aortic valve patient. Low degree of oversizing recommended up to 10% because to avoid potential annulus risk of annulus rupture. Post-dilatation may be required because sometimes the valve not open fully, and in post-dilatation use low radial force also to avoid potential rupture of annulus. As I said, we need a more randomized control trial, which give us answer for which valve is optimal and size and methodology. I give you two presentations of our two cases. We perform TAVI procedures in our center routinely since 2022, and up to date perform 277 this intervention, and we have 12 patients with bicuspid aortic valve aortic stenosis. First patient is a male, 63 years old. In that patient, due to aortic dissection in 2008, performed aortic repair with interposition tube graft. Chronic para-aortic hematoma remains after that intervention. Now, echo shows us severe aortic valve stenosis. According to CT scan, we see that is a bicuspid aortic valve stenosis with severe type 1 classification. Vascular access from iliofemoral artery is okay. For intervention, as you can see, that is the end of the tubus graft, and this is okay, good for information to see how we can implant the valve. According to the measurement, we choose Evolut Pro Plus 34 TAVI valve. We perform pre-dilatation to this patient. In every TAVI procedure, we use 3-cusp and cusp parallel U to orientation. And when we implant the valve, but valve not fully open, as you can see, and we perform post-dilatation, and this is the final result in that patient. Another patient is 77-year-old male patient with previous cardiology history. He has STEMI in 2011, and primary PCI was performed that. Now echo shows severe aortic stenosis. His STS score is 4%. This, you can see that the measurement of the aortic valve complex. It is supraannular dimension and annular. This is the dimension of the coronary artery height. Because of the little bit lower takeoff of the left coronary artery, we decided to use balloon expandable valve. This is distribution of calcium, you can see. And another problem is the vascular access. As you can see, it is occlusion of right iliac common artery. Then we decided to perform our first access from left femoral artery and secondary access from left radial artery. According to the CT dimension in that patient and findings, with that patient, we decided to use a cerebral protection with Sentinel. You can see the hemodynamics in that patient is huge gradient in transaortic gradient in that patient. We perform a pre-dilatation and implanting the octacore 29 millimeter valve with 9% of oversizing with good angiography result, and the hemodynamic show us so good result, and after that we check with echo, also low gradient after that implantation. This is our teams who performs TAVI, and thank you for your attention.